So hello everyone, welcome back to my another video. So in this video we'll be discussing about the obstetric anesthesia. So I have divided this topic into two parts, the topic called obstetric anesthesia into two parts. So in this module we'll be discussing about the anatomical and physiological changes, and in the next module we'll be discussing about the anesthesia for LSCS and labor analgesia. So let's start without any delay. So anesthesia can be employed in obstetrics, that is in pregnant females. So if we talk about this in brief, there are two types of anesthesia which can be administered. The first one is labor analgesia and the second one is anesthesia for LSCS, that is lower segment cesarean sections. I repeat, there are two types of anesthesia which we can administer. The first one is labor analgesia and the second one is anesthesia for lower segment cesarean sections, that is LSCS. So please have a note of it. So now moving to the subtopic, the anatomical and physiological changes in pregnancy. So pregnancy is the only physiological state where most of the physiological parameters are abnormal. Please have a note of it. It is a very important point from the exam point of view. I repeat, pregnancy is the only physiological state where the most physiological parameters are abnormal. Then moving to the next point, various changes takes place during ANC period, that is the antenatal care cover period, which can be grouped as anatomical changes and physiological changes. And these physiological changes occur due to the hormonal changes. I repeat, the various changes takes place during ANC period and which can be grouped as anatomical changes and physiological changes. So at first we'll be looking at the anatomical changes. So here there is a list of few anatomical changes. The first point over here mentions that uterus in nulliparous females, that is non-pregnant females, that is the female who has never been pregnant. So uterus in nulliparous woman is about 6.5 cm long and 30 grams in weight. I repeat, uterus in nulliparous females, that is the non-pregnant females, is about 6.5 cm long and 30 grams in weight. Then moving to the second point, at term or when a pregnant female is full term around 36 to 40 weeks, the uterus occupies whole of the abdominal cavity and it is about 32 cm long, 24 cm wide and 22 cm deep and weighs around 1 kg. Please mark the points over here that in nulliparous females, that is when pregnancy is not there, the uterus weighs about 30 gram, but in times of pregnancy the weight of uterus changes to about 1 kg. So please have a note of it. The next point, uterus grows out of pelvis at 12 weeks due to hypertrophy of muscles and has liberal blood supply and lymphatic drainage. Then the cervix becomes blue due to vascularity and secretions are increased and it becomes copious in nature. Then the last point over here, fallopian tubes become stretched and more vascular. Here are a few more points of the anatomical changes. So let's read them one by one. Round ligaments are thickened and hypertrophied. Then the ovaries become enlarged. Then vagina shows increased vascularity and more copious secretions. Then the next point, abdominal wall is stretched and grows thinner. Stria grandum appears on the surface of the skin of abdomen due to rupture of the subcuticular elastic fibers, which later heal, leaving the pearly white linea albicans as the pregnancy commences. Breast increases in size, nipple becomes more erectile and areola is deeply pigmented. The weight gain is most obvious sign in pregnancy. The total weight gain is around 5 to 9 kgs and sometimes even above 10 kgs, up to 15 kgs. And the total body water increase is around 7 to 10 liters. So these were some points under the anatomical changes which we looked just now. I insist, please maintain a notebook and go through it twice a day Now moving to the physiological changes. So at the cardiovascular level, there is increase in intravascular fluid volume by about 1000 ml, that is 1 liter. Then there is increase in cardiac output, about 40% increase, and as it reaches to 36 weeks of pregnancy, it increases up to 60%. And during active labor stage, that is when the pregnant female is about to deliver the baby, the total cardiac output increases even more than 60%. So you can see how much drastic physiological changes occur during pregnancy. Then there is decreased systemic vascular resistance due to peripheral vasodilation. I hope the cardiovascular section of the physiological changes is clear. Now we'll move to the respiratory system. So there is engorgement of upper airway with edema of upper respiratory tract due to capillary engorgement of mucosal lines. Then there is decrease in FRC, that is functional residual capacity of lungs, and residual volume is decreased due to enlarged abdominal wall as it pushes the diaphragm upwards. Then there is marked reduction in the partial pressure of oxygen due to decrease in functional residual capacity and residual volume. Then we move to the CNS section, that is central nervous system. So here the decreased requirement of inhalational agents due to sedating effects of the progesterone. As we know that progesterone is secreted widely during pregnancy. So there is decreased requirement of inhalational agents due to sedating effects of progesterone. Please mark this point because this is very important from the exam point of view. Then there is engorgement of epidural veins because of increase in abdominal pressure, resulting in pumping effect on CNS. Hence, dose of spinal anesthetics is drastically reduced. I repeat, there is engorgement of epidural veins because of the increment in the abdominal pressure, which results in pumping effect on CNS, and hence the dose of spinal anesthetics is drastically reduced. Exaggerated lordosis happens due to increased abdominal size, which also contributes to the engorgement of epidural veins, as we already looked at the point earlier, and hence decreased dose of spinal anesthetics drugs. I repeat, exaggerated lordosis happens due to the increased abdominal size, and which also contributes to the engorgement of the epidural veins, and hence the decreased dose of spinal anesthetics. Then moving to the renal systems. So here the RBF, that is renal blood flow, and GFR increases. There is decrement in BUN, that is blood urea nitrogen, and the serum creatine level also decreases. Then the next point, proteinuria and glycosuria are the common things to happen during pregnancy. I repeat, please mark the points. The RBF and GFR rates increases. There is decrement in the blood urea nitrogen level and also decrement in the serum creatine levels. And the last point over here, proteinuria and glycosuria are actually very common in pregnant females. Then moving to the hepatic systems, the SGOT levels increases, so as the LDH levels and alkaline phosphatase levels. I repeat, the SGOT, LDH and alkaline phosphatase levels, all of them increases. Then the hepatic blood flow and serum bilirubin is unaltered. Please mark this point over here, that the SGOT, LDH and the alkaline phosphatase levels fluctuate, that is they increase, but the hepatic blood flow levels and the serum bilirubin levels are remain unaltered, that is unchanged during the time of pregnancy. Then moving to the GI system. So the first point over here, esophagitis and heartburn due to shift in position of stomach as the uterus grows. Then the gastric volume is decreased, and there is increased risk of aspiration in all pregnant females. I hope it is clear to you. Then moving to our last topic, that is clotting factors. This is the last point in the physiological changes section. So let's discuss it too. Pregnancy is also suggested as hypercoagulable state. That is the factors 7, factor 8 and factor 10 and the plasma fibrinogen levels increase in pregnancy. I repeat, The factor 7, factor 8 and factor 10, along with plasma fibrinogen levels, all of them increase in case of pregnancy. So this brings to the end of our lecture, the module 1 of the obstetric anesthesia. So I hope you enjoyed our lecture, and if you enjoyed it, please do share with your friends, and make sure that if you are new to our channel, please do subscribe to the Encephalomist.